You've been conducting the PEAK trial. You were looking particularly at metastatic colorectal cancer and ways of improving therapy. What were you trying to do in this study?
In patients with RAS wild-type metastatic colorectal cancer, we have today two possible new drug treatments. One is anti-EGFR monoclonal antibodies. We have Panitumumab and Cetuximab, and the other possible treatment is Bevacizumab. So it's not possible to combine them because we have negative results when we have tried to combine these two different drugs, and we have to use one first and then the other. And we don't know which is the best sequence, which targeted agent should be used in first line. So in this trial, we compare both treatments, Bevacizumab versus Panitumumab, combined with chemotherapy in first-line treatment of RAS wild-type patients with metastatic colorectal cancer. It's not the only trial that have done this. There's another two trials.
All the patients had FOLFOX, of course.
Yes. The backbone was FOLFOX, and FOLFOX were combined one with Bevacizumab or with Panitumumab.
Okay, so you've gone head-to-head with an EGFR-based therapy against the VEGF therapy. Okay. What happened?
Really, in the PEAK trial, the PEAK trial is not a very big trial. It's only a randomized phase 2 trial that originally include 285 patients with KRAS section 2 wild type, but after the trial have been conducted, we know now that only patients with K and NRAS wild type tumor benefit from this drug. So we have to repeat the analysis, focusing on the patient with K and NRAS wild type. That was really only 170 patients. So it's not a very big number of patients.
But what happened?
What happened in this group of patients? The primary endpoint of the trial was progression-free survival. We have now analyzed, we have the final results of the trial with longer follow-up, with mature data, and progression-free survival is better in the Panitumumab arm. That was the primary endpoint of the trial. This response rate was a secondary endpoint, according to this criteria. Was not different between the two arms, but overall survival, what was a secondary endpoint, in the first analysis that was published 1 year ago in the JCO, numerically median overall survival was quite more important in the Panitumumab arm, and the difference was more than 12 months. But in this first analysis, the follow-up was short, and this survival data was not mature. We are presenting now mature data of overall survival. It's a very important thing of this presentation, and with longer follow-up, with mature data, in this final analysis, overall survival is still numerically better in the Panitumumab arm, but the difference does not reach the statistical significance.
Right. Now, it is important to get that statistical significance. What should doctors be taking home from these findings?
I think there are an important message. It's not clear which new targeted drugs, VEGFR inhibitor, Bevacizumab, or anti-EGFR inhibitor is better in first line. The PEAK trial is not the only trial. We have another two trials, the Fire-C trial that obtained better overall survival with Cetuximab, that is another anti-EGFR monoclonal antibody, versus Bevacizumab. So two trials with better results with anti-EGFR, but we have a third trial, that is the CALGB trial. We have not all the data from the CALGB trial yet, but with the data we have no differences in terms of overall survival. So it's not clear, but taking all the results together, there's a bit more data in favor today of the anti-EGFR monoclonal antibodies.
Right. However, toxicity would come into it also. Are there different toxicities between these two different approaches?
Yes, really, the toxicity is really very different between these two approaches. The main toxicity in the EGFR monoclonal antibodies is skin toxicity. It's not a life-threatening toxicity, no dangerous toxicity, but is very bad for the quality of life of the patients. And the main toxicity of anti-VEGFR are mainly vascular toxicity, hypertension, arterial thrombosis. That is very important toxicity, but it's infrequent. So really, there are different toxicities. Probably for the quality of life of the patient, skin toxicity is a bit more problematic, but if you really have improvement in important results like overall survival, yes, I think if you balance the toxicity and the improvement, I think it's really probably today in some group of patients, probably we prefer TFR monoclonal antibodies.
Could you then sum up very briefly the interim recommendations to doctors?
I have another data that we have presented that is, although the response rate according to this criteria is similar between the two arms, if we consider the quality of the response, is better with the Panitumumab. Response lasts longer, is obtained earlier, and is deeper with Panitumumab. And other trials have also observed this. So for some kind of patients, probably patients with potentially resectable disease, that you need a response, a very good response, because you can perform a surgery and can be cured.
Right. Are you leaning in the direction of EGFR-based therapies rather than VEGF-based therapies, or not?
I think that probably we would need a better selection of the patient, an even better selection, because we have first KRAS SON2 mutations, then we have other RAS mutations, K and NRAS, and better selection, more improvement with anti-EGFR. Probably the next step will be BRAF mutations, other possibilities, but with each step we are focusing more and more the benefit in a very selected group of patients. And I think that today, with RAS wild-type tumors, probably we have better results, especially if you need a response, patients with potentially resectable disease, patients with very aggressive disease, with anti-EGFR monoclonal antibodies. But to use bevacizumab is another option. It's not forbidden. It's open, the question.